When Dr. Paul Farmer says healthcare for all, he means everyone. Next on Wyoming Chronicle. Hello, I'm Richard Ager. Welcome to Wyoming Chronicle. If you've ever had to make an emergency visit to the hospital, you probably remember what a stressful experience that can be. A ride in the ambulance with siren wailing, doctors and nurses all about as they rush to treat your problem. Well, now imagine no ambulance, no doctors to help you, and your family has to haul you in a wagon or a makeshift stretcher over rudimentary roads for a day just to reach a person with even basic medical training. Well, that's access to health care for a third of the world's population. In 1983, a young Harvard medical student, Paul Farmer, decided he would change that equation, and along with co-founder Ophelia Dahl, he established Partners in Health, which now provides quality medical care for the poor in more than a dozen countries. We'll have part one of their interview with us in a moment. But first, a bit of background. An eager crowd files into the event hall in Jackson Hole, Wyoming. It's an event for Partners in Health, and everyone has come to hear stories from two individuals who have made a difference. Ophelia Dahl is the daughter of famed children's author Roald Dahl, the author of many books including James and the Giant Peach and Charlie and the Chocolate Factory. At age 18, Ophelia left England for Haiti to volunteer at a children's orphanage, and there she met Paul Farmer.
We both saw things in that year, 1983, that we hadn't seen before. I mean, I'd never seen the way hunger can work its way through a community or the way epidemic disease can. I'd never seen anyone get, much less die, of malaria, tuberculosis. And then one of the worst things that we recall from that first year was someone dying in childbirth.
Those experiences stayed with Farmer and Dahl, who would work to establish greater health care in Cange, a village on the central plateau of Haiti. In 1987, Ophelia Dahl, Paul Farmer, and fellow Harvard med student Jim Kim established Partners in Health. They had no funds, but high ambitions to bring health care to the neediest. Fortunately, another founder had deep pockets: Boston real estate developer Tom White.
Well, give me three good reasons why I should die with a lot of money. What good does it do? I've taken care of my wife, my kids are okay. When I climb into bed at night, okay, and I pull the sheets up, I thank God. I say, holy mackerel, these people are sleeping in mud. We fixed every home for like 2 miles either side of our clinic. We put in a concrete floor and a tin roof. This is suffering at its worst.
Over the past quarter century, Partners in Health has expanded its services to the poor around the world, including the U.S. Paul Farmer has worked tirelessly to treat individuals while spreading the medical gospel of health care for all.
This is a district of over 400,000 souls, and in 2003, 2004, there was not a single doctor, much less a district hospital. There was a health center here, but really people had to go to Ruangeri, to the Ruangeri District Hospital, which, as you know, on foot, I don't know, it's many, many hours on foot. And in fact, it's an hour and a half, 2 hours in a vehicle.
In the summer of 2012, the Butaro Cancer Center opened, the first in Rwanda. Partners in Health now provides medical care in a dozen countries to more than 2 million patients each year. But this project, a new hospital in Mirabelais, close to where Paul Farmer began his service in Haiti, has special meaning.
Today is the culmination of 25 years of dreaming about better medical care for people in this town.
The ribbon cutting in November 2012 also featured fellow Partners in Health founder Jim Kim, now president of the World Bank. Old friends, still working towards their ultimate goal.
Global health equity. But it's, in the end, probably one honest way to describe what we have to move towards as a species.
Ophelia Dahl, Paul Farmer, thank you for joining us.
Thank you for having us.
Let's start with a little bit of biography, if you don't mind. Paul, a story from your childhood I thought was a bit revealing. In the 4th grade, you would actually give learned talks about frogs, salamanders, and other amphibians. One of your sisters remembered thinking we should just beat them up and go out and play, but actually they stayed, didn't they?
Yes, my sisters and brothers have been tattling on me, I see. Yeah, they were good. They were a good audience, my first classroom, and pretty supportive lot, actually.
And I think, revealing your real love of science and understanding what lay beneath what most kids might regard as just grown-up tadpoles.
And I still have that today, fascination with the natural world, and kind of switch my interest in creatures great and small to creatures human. But I'm still very much interested in some of those same things I was as a kid.
Now, for a time, you and your family actually lived in a bus known as the Bluebird Inn, and that had actually previously been a mobile TB clinic. Did you know that at the time?
I'm not sure I did. I mean, I know I knew it because there was an X-ray machine in the bus when we acquired it.
Well, that's a giveaway.
That's a giveaway. But what it really meant, I don't really think any of us understood. The X-ray was tall enough so they had to take out the top of the bus, and that's where my father made bunks for the 3 of his sons. Mine was the top bunk with all the nature magazines crammed in. And yeah, so we knew it was a tuberculosis bus, and but little did I believe that I'd be doing, seeing TB patients the rest of my life.
Almost seems like a predestiny. I mean,
of course, my brother lived in the second, at the bottom bunk. He was in the same bus, but he became a professional wrestler. So I don't think it was bunk as destiny, really.
Given that background, in childhood, I mean, did you feel deprived or poor at any point, having to live in a bus?
No, not really. I mean, we had an intact family. Both our parents were there. It was crowded, but we were most often in Florida when we were living in the bus, and went to school every day and had 3 squares, and had a lot of attention paid to us. Not always the same kind that I see paid to kids now, but we had a very it was difficult, I'm sure, especially for my mother, to take care of 8 people on a bus, but we enjoyed it. That's my recollection.
Ophelia, you of course had a very different kind of upbringing, daughter of a famous children's author, Roald Dahl, and he encouraged you to see another side of the world, and I guess you really took him at his word, didn't you?
I did. He'd lived in a time, I think, when it was very usual for people to go on an adventure, and if you went off an adventure, then you really did go for a long period of time. You couldn't contact home very easily. I think it was 3 or 4 weeks before a letter would get home. And for me, actually going off to Haiti for the first time at 18, it was a similar thing in that it was very difficult to stay in contact or make phone calls. So you knew you were away.
And this was no tourism kind of tour that you did. You were working in an orphanage for handicapped children in Haiti.
Yes. I
mean, how transformative an experience was that?
Utterly. It would be impossible, I think, to go from a bucolic English village, even if you'd traveled as we had growing up to Europe and that sort of thing, and to end up in Port-au-Prince and not feel in some way transformed. I think you'd have to be a pretty closed person. I think the difficulty was not knowing how to do all of that translation, not knowing how to take all of that in, think about it, process it, connect it to other things in the world or in life, in my short life, and feel as though you could do something.
How did you two happen to meet? And I will start with you. We'll probably get slightly different versions.
We met in a place called Mirebalais, which is right in the middle of the central plateau of Haiti, and I had been going out there to do really sort of rural mobile clinics with this ophthalmic group, and it had been we'd been stationed in the clinic that was in the center of town. I'd gone off to make a phone call, which was a several-hour process if you were lucky. I had received some correspondence from my dad saying that to call home he had some news. So I went off to do it, and then I remember coming back from the center of town, and as I walked down, I looked up at this little house in which we were staying, and there was someone standing on the balcony, and I have to confess that my immediate thought wasn't, oh hooray, someone new to talk to. It was sort of, oh, someone else to talk to now. I'm going to have to, get to know someone. And because I think in part, when you are going through these experiences, you sort of you want to be able to have time to process these things on your own. You spend most of your day out in the villages doing these things. But I looked up and I walked up the winding road and met him, and pretty much as soon as I met him, we started talking, and there was just great simpatico, and I think we stayed up the rest of the night talking. I don't think we went to sleep.
You agree with all that?
That's my recollection as well.
That's your story and you're sticking to it?
Exactly. Yeah, I'd come out there. I had a heads up that Ophelia was out there. I didn't really know who she was, or that she was 18. But you know, I heard
you're
this
probably
is really,
the only two non-Haitians there, were you not?
There were a couple others. There's one or two
Almost,
others, yeah, but very, very much. So I had been working with was starting to work with a Haitian priest and an Anglican priest and his family, and co-workers who were doing education, and also some, you know, we now know how rudimentary the healthcare was, how actually poor quality it was. We didn't really understand. We were starting to, and although I had, you know, studied a lot about Haiti and in fact anything I could, I'd read already, and was learning the language, and I still had the same challenges that Ophelia mentioned. How do you process, to use that jargon, how do you understand what it is you're seeing? How do you narrate a place so different and yet so connected even to yourself? So we were hungry for company, but the right kind of company that one could confide in and say, hey, what do you make of this? And describe something new that one was seeing. I'm using the third person because I suspect now, almost 30 years later, and being a teacher of people that age, how we were when we started, that most people go through this. The shock of the new, and also seeing things that they wouldn't see in a comfortable English village or even a campground in Florida. You don't see people who are, at least I never did in rural Florida. I see people who are hungry, and or people being chippy.
Well, the entire society really, for the most part,
Yeah.
being that way, not just an underclass.
And there was also this palpable tension there then, in 1983, 1984. There had been a family dictatorship in place for, at that point, 27 years, and it was about to fall. And all that would happen really less than 3 years later. So we were really seeing also the tail end of a long family dictatorship, and there was a lot. One of the things that brought it down were the food riots, which started in 1985. So we didn't know all this was going to happen, but we did know that there were momentous events afoot, and also we understood that these were having a momentous impact on each of us. So we did hit it off, and from that time on, and that's 30 years ago, we've been having, in some ways, the same conversation. Obviously, the conversation changes as we do. We get older, we have our own families. We've worked now in 11 other countries, but it is, in many ways, the same conversation.
Well, I think that's what's one of the things that's so fascinating is you have this enduring partnership. You've gone through different iterations of your personal relationship. You were a couple for some years, then not. You have your own families now, but still, the conversation continues. And I'll jump to 1987, of course, because that's the year that Partners in Health was founded by you two, and of course your friend Jim Young Kim. And at that time, I think it had more modest aims than it was really to provide some financial support for the small clinic that you had going in Haiti.
Well, we actually stumbled through that the first year, because if you're providing support for one institution, you really wouldn't have set up the same structure that we did set up, which is in American legal jargon, 501c3, nor could you have one donor. You really had to have higher aspirations. And we had also, of course, had experience between 1983 and 1987 of, just to give an example, I had started medical school at Harvard, and I saw people, and we saw people going back and forth from places like Haiti, sometimes Haiti, into a teaching hospital, like the ones that were surrounding Harvard Medical School. And we thought, that we'd worked out that the larger goal was not to help one particular village in one particular country, but to take on this really grand problem of health disparities. And we knew that they weren't ever really local, that they weren't in one city or town or country, but they were always global in a sense. Like if you have a kid who's sick in Liberia and injured in Liberia, and you'd think also about perhaps about bringing him to proper care. So we didn't really set out in 1987 only to do to work in Haiti, or only to, much less Conge, or only to have one or two people supporting us. We really had big aspirations from the beginning, and we can remind ourselves that just by going back to look at the materials we wrote in 1987, the mission statements, etc.
But we did start somewhere, and that is true.
That's right.
So
first the seed, then the oak.
First the seed, exactly. And I do think that that's important. And I remember having a conversation with Paul before 1987, probably 1985 or so, when we were talking about this, and he had set out actually an arc that we pretty much stuck to. I mean, not because we had decided that we were going to adhere to a particular plan, but he was able to see forward 10 years and say, here's what I think we should do. And the reason he did that is not because he said, I have this grand plan, because I would say, so if we do this, then what? And he would say, well, then, then we can follow go to the next place and do this. And then, so it became this big narrative. It's true, but I do think it's important to say, for one time, we set our sights on building a clinic in central Haiti, in the place Conge, where there were a lot of water refugees. It was in deep and dire rural poverty, and it's also what the community had said that they wanted. So, but the clinic very, very quickly morphed into something bigger, but we did set our sights on that. And for me, a fundraiser, it's easier to do that, to go back to England and say, hey, we're building a clinic, than, hey, we're tackling health disparities around the world.
Well, and of course now, 25 years later, it's considerably larger, is it not? I read you employ something around 15,000 or so employees, and only about 1% are actually based here in the United States. The rest are in all of the countries right where the problems are.
That's right. That's right. We knew that for sure, that part of what we would need to do would be to train local people, and to make very close connections with other people who would train local people. So
and what kind of difference does that make? Not parachuting people in, but rather hiring the locals.
You're going to change a system within a country if you do that. Otherwise, the model that we had seen, and we went past maybe 20 of these houses as we drove from Port-au-Prince up to the village in 1983, 84, 85, you would see these rather beautiful bungalows, these sort of ranch houses. And I would say to Paul, why in the middle of what are those? And he'd say, well, those are houses that belong to missionaries or people who'd come here to, say, build a dam, or who'd come here to start a project. Inevitably, they were empty. So people come and they go, and that's human. So really, to come in and change things for the long term, it's not a question of saying to people, gee, Richard, if you're going to really do this kind of work, you have to uproot everything in your life and go and live there for 50 years. You have to go in and change systems from within.
Now, there is a very strong moral, I think, dimension. When you look at the vision statement, for example, of Partners in Health, it says, our mission is both medical and moral, and it goes on to say, whatever it takes. And I think there's a good example of that, because I also read that the first microscope for your clinic in Conge was, well, actually stolen, I hear, from Harvard Medical School.
That is not but rumor.
Well, you labeled it redistributive justice, and you also added we were just helping them not go to hell. So
that just shows you not to talk on the record to writers.
But I mean, clearly, it's a demonstrative of the kind of vision that I think you have brought to this, and back to your
larceny vision.
Well, back to your medical education. You said that your mentor was actually a 19th century figure, Rudolf Virchow. I probably didn't pronounce it right, but he was the founder of what's called social medicine. He traced the role of poverty and malnutrition in disease outbreaks, and he wrote, I'll quote, "Medicine is a social science, and politics is nothing but medicine on a mass scale." Clearly, you took him at his word.
Yeah, I did. And just back to the perhaps amusing anecdote of the microscope. It's really much more, of course, the vision is, again, a little bit bigger than, you know, it's about redistribution in a good way. You know,
well, I think Harvard Medical has forgiven you, clearly.
Well, no, Harvard Medical School aided and embedded me all along the way, and I'm very grateful. I'm now a professor there, and I've never left. I went to Harvard in the fall of 1984 and have been there ever since. And so a lot of the work that we've done in Haiti has revolved around our own students and trainees and the faculty at the teaching hospitals. And they share, I think, this view of health disparities as being objectionable on moral grounds, as you say. You know, even inside, this summer, I just came here to Jackson Hole from Africa, from Kigali, and you can imagine the kind of disparities that you see on a trip like that. But inside this country, you know, and I was also in the Navajo Nation not too long ago. You could see it in the poor parts of an American city. You invariably see enormous health disparities. And so how do you address those without a vision that comes from social medicine? Back to your question. And there are almost two ends of that approach. On the one end, you find the deliverables, like a microscope, a medicine, you know, a diagnostic test to find out what is a patient, what is he or she suffering from, and how can I make sure they get better. So that's the late in the game, but far more upstream, there are problems around housing, food security, and job creation. You know, one of the things that Ophelia didn't mention about job creation is not only are you able to change the system from within, you're also helping poor families break that cycle of poverty and disease because they have someone in the family with a job. And so I think Virchow's vision went from the microbiologic all the way to the large-scale social forces that make some people sick while protecting others from sickness.
And he saw no separation there. And
he saw no separation.
Neither do you, obviously.
And it's hard work, you know. It's very hard work, not just for a doctor, but for anyone who's doing this work to be able to see the small-scale problems and at the same time contemplate or even attack the large-scale social forces that make people sick. It's very hard to do.
And I think a large part of what you do is help motivate others as well. I mean, Ophelia, those who work with you at Partners in Health are often described as seeing this not so much as a job as a calling. I mean, how would you describe what motivates really the thousands who work around the globe with you?
I would say they feel motivated to be able to change what they see in front of them. I think that makes a huge difference to people. You know, we have discussions a lot of the time about, you know, what's called again in jargon burnout, and you know, how people go on. I think it's the ability to keep seeing change, however incremental, and to know that you can, as part of a team, make a difference. I think that's what motivates them, don't you?
Yeah, I do. I think that's you need to remember that we need to remember that although everyone can have their own quest for personal efficacy, and we're exposing them to, or they're exposing themselves to very difficult circumstances, and those are the circumstances of the people we serve, and to, you know, to keep them engaged, to keep the people who are making this voluntary shift, like she did and I did, because some people don't have a choice in the matter, they're born into those conditions, to keep them happy, vibrant, productive. I think it's important to be able to see, hey, this patient got better, this clinic got built, this hospital was built.
You know, many point to the kind of example that you have set along the way too. One of the things I found really interesting was in Haiti, fairly early on, you learned to deal with the Haitians' belief in sorcery, and why that belief is there. How did this affect your practice of medicine there?
Well, I mean, in a way, it improved my practice of medicine in the United States, later, and in Africa, in Rwanda, Malawi, Lesotho, Russia. Because what I learned in those first years when I was studying, first of all, it was very frustrating. I won't hide that from you. And I'm not sure that works itself into my writings, how personally frustrating it was to see someone with acute malaria, say, or tuberculosis, who thought that he or she was the victim of sorcery, which is, of course, the ill will of a neighbor.
A spell on them.
Yeah, the ill will of a neighbor, not just somebody, their neighbor. And that was very frustrating for a lot of reasons. One, the obvious, it could make it difficult to treat that patient with the things we knew I felt sure could cure him or her. But the other thing, of course, is sorcery accusations involve enormous conflict. And it's interpersonal conflict right there in your face. So I don't want to suggest that I'm in any way charmed by this, but what it taught me then was that people have strange ideas about what causes illness. And that's true whether you're in rural Haiti or in Boston or in Berkeley, California.
And you're also an anthropologist too, which of course helps inform your understanding of this. You know, one thing that struck me is also, I mean, all hospitals have a chapel. Yeah. And many people will pray for a cure, so where exactly is the line?
And I think that's right. I think there is there's a good relativist approach to this, which is the one that you just took, that people everywhere in the world have their own means of explaining illness, of understanding what it comes from, and how best to palliate it. The sorcery accusations, although conflictual, were almost never in any way lethal in and of themselves beyond the lethality accredited to the sorcery. But in other words, it involved fights or arguments so much as, and again, this is not to elevate them, it's just that I learned early on, before most medical students do, I was in my 20s, that all over the world people would have these kinds of, let's just call them non-medical, non-biomedical, non-scientific ways of understanding their illness. And of course, that was better to learn it young than learn it later.
Our interview with Paul Farmer and Ophelia Dahl will conclude on the next Wyoming Chronicle. Be sure to join us for that.